Today we have a fantastic guest. Dr. Krista Hubbard is with us from Horizon Health Works in Marquette, Michigan. She's actually a new member of the Headway Foundation Medical Advisory Board. She is a board certified from the American Chiropractic Neurology Board, and she's been on the board since 2015. She's a fellow of the American College of Functional Neurology. She's a fellow of the American Board of Vestibular Rehabilitation. She's a fellow of the American Board of Brain Injury and Rehabilitation. So she's got a lot of credentials to tell us all about functional neurology today, which is the subject of the webinar. So if you want to just go ahead and start telling us a little bit about yourself, about your practice, and a little bit about functional neurology.
Okay, well, I'm happy to be here today. I think this is a great cause to be a part of. I think that concussions are, a very isolating event, and I know because I lived through too many to count, too many that were undiagnosed. And so first off, I just want to say that my number one goal in being here is as a patient advocate, and secondly, as a physician, to hopefully give resources in order to help enable patients and families have the opportunity to learn more about what may be out there treatment-wise, and also as a kind of a call to action collectively with all of us physicians to always do a better job in serving others. So my history in a nutshell is I grew up in northern Michigan, and I was a crazy little kid that liked to go really fast on skis, and there was no stopping me. So starting in 4th grade, I was out there, it was windy, it was cold, the wind was coming off Lake Superior, and my parents would say, go inside and warm up, and I said, no, I want to go around those gates again. So that led me on a career to get a high school scholarship at Gould Academy in Bethel, Maine, where I was able to ski race there. And then I also was able to compete at the University of Vermont for the Catamounts, go Cats. And there I suffered some more injuries. My undergrad at the University of Vermont was in mechanical engineering. So I like systems, I like analyzing, I like understanding why, I like understanding how, and I like understanding what we can do to help people thrive and function the best possible. In a nutshell, I had multiple concussions along my sports journey. On average, we're going in between 30 to 60 miles per hour. It's a high-risk sport. If you don't fall, we're not going for it. So that's kind of part of the thing. If you're taking not enough risks, you're not going to crash. So it was like, you crash, okay, cool, you get back up. In my engineering career around my junior year, now retrospectively, I realized with the training that I have that my concussions were starting to take a toll. One of my biggest attributes that I had school-wise was always being able to visualize a picture in 3D. And I started to lose the ability to see that picture in 3D. We were building something in lab, and I was thinking about how to make this 3D object with a computer program, and I couldn't see it in my head. And I really freaked out. I was like, this is not okay. This is something that's not good for an engineer, and I tried to, even then, think about what I could do to solve and fix that problem. Fast forward a few years later, I'm done with engineering school, done with my sports career. I was in a severe rear-end car accident. I was stopped. The driver behind me was going 40 miles an hour, so severe whiplash. And this ended up ultimately resulting in a neuromuscular disorder from a concussion, from a whiplash, called dystonia. And dystonia is a neuromuscular condition that we can talk about a little bit more, that involves your muscles doing things that you don't want them to do, specifically contracting when you don't want them to contract. So my neck was the first area of where dystonia started. It started on my right side, but dystonia, like a lot of neurological conditions, is progressive. And just like a lot of concussions, we can actually, instead of just stagnating in our function, some things can actually get worse depending on the tasks and the environment that we're in. So we have to give up things that we love, which is unfortunate. And so long story short of it all, and I'm sharing this mostly so that you can, that I can relate to you. I can relate to people who are suffering. I get it. I got your back. I understand. And let's work together to do our best. So long story short of it, my condition was progressing to the point, luckily I'm left-handed, but where I would try to move my right hand, so specifically things like typing or using a mouse, and my whole right side would contract, and it was really ungodly painful. And it felt like I was doing, like picture like a wall squat, or like you're doing something like really high intensity. But that was just like that, just doing a simple task throughout the day. So over the course of just a couple of years, it went from just a focal little neck dystonia into my whole entire right leg, to the point where when I was in the water in the summer of 2009, I went to move my right arm and my right leg moved, and I was ready for my life to be over and in a wheelchair. So each day that I'm here, and even this opportunity to be here today, is a blessing for me. And I hope that we're able to, that I'm able to give you something that is valuable. So thanks for letting me be here today.
Yeah, and your positive outlook is definitely something I think that everyone can walk away with, having learned something. It's definitely commendable, and we appreciate your time.
Thanks.
So why don't we get started with sort of your discovery of functional neurology, sort of a breakdown of what it is at its root, and then sort of how you became a clinician.
Yeah. So I think that, just so you know, it's hard for me to talk about myself. So, but I think that in sharing this story, I hope that it helps to open up the door of communication, and then we can go from there. So while I was in chiropractic school in Iowa, I went to chiropractic school because when I was in undergraduate school as an engineer, a chiropractor helps me out. And I said, well, what the heck is this? Why did that help me when nothing else had? And then me and my engineering brain said, I'm going to go to chiropractic school to figure it out. Much to my family's like, what are you doing, So I show up at chiropractic school with a lot of questions, and I wasn't getting a lot of answers. So this led me on a quest to look for answers to why moving a joint, and why doing something on a muscle would be able to allow me to think more clearly. That didn't make any sense to me. There was no reason for it that I could find in my standard curriculum. So I was able to, while I was at school, I was going to different clubs, and I was kind of a pain. I was going to all sorts of different clubs to learn as much as I could from different people. And I came across the Carrick Institute and the Carrick Institute curriculum. And I was like, wow, here's a curriculum where we're learning about the brain. We're learning about how to assess the brain when it comes to movement, but also how, when we're able to look at how the brain helps us live in our world and have a more productive quality of life. So I really started taking a lot of classes through the Carrick Institute, and it's ironic, and a blessing for me is that I was already several courses into the Carrick Institute curriculum while I was in school in Iowa when the car accident happened. And so when that moment happened for me, when I was in the water in a lake in North Dakota, and I moved my right arm and my right leg moved, that was my uncle moment. That was my my moment where I knew that my personality wasn't going to let me get through it. And because I'd always that's the athlete mentality. You can push through things. You can get there because you're going to work harder. You're going to push through the obstacle. And that I'm sharing that also because I think so often when we're coming into things from an athletic mindset, we're used to pushing. We're used to always going past the point of pain. And when it comes to neuromuscular rehab and rehabbing concussions, we have to draw back. And that's counterintuitive to what our senses have kind of made us who we are, So what happened is then I contacted the Carrick Institute, and at that time I had never met Dr. Carrick before, and I said, hey, this is my deal. I have my own practice in North Dakota, and had at that time my daughter was 5 months old, and I said, I'm going down fast, and I think I'm going to be in a wheelchair, and everything's going to be over for me. And Trisha Carrick, Dr. Carrick's daughter, was able to get the message and relay it to her dad. And her dad said, Trisha, I'm a little busy right now, because he is. And then she asked for a favor, which thank God she did. And I was able to fly to Amsterdam in September of 2009 and work with him there as part of a clinical training that he was doing. And I was a patient. And I remember sitting there, and I'm sharing this too because what Sarah and I were just talking about prior to this conversation is when you're injured, and I get this, you want to know why you're feeling the way you're feeling. And I remember getting there, and it was a struggle just to get on this flight to Amsterdam. I could barely lift my bag above the thing to get it in the overhead storage compartment. I was by myself. I was with people from all over the world at this training. You know, there was like 150 clinicians in there, and there I am, a clinician still at the time. And all I wanted to know was why. Why had my system gone from a competitive athlete and 5 years later, I'm having trouble moving? And the answer to that now, as a clinician, is so obvious, because the systems that we have in place is, they're smiling, so I'm smiling too, but the systems that we have in place to allow us to be healthy, to allow us to perform better as athletes, where we practice and it makes perfect, and we have these redundant systems so that if we're on one foot for a shot, say when you're playing hockey, or you're doing, you know, something where the snow is a little different texture than you anticipate it to be, and then you're able to change your turns so that you can make the gait better. We're always constantly adapting, and our system is always getting feedback into our brain so that we're able to calibrate our motor output and our programming. But the thing is when there starts to be errors in the system, the error begets error, and then we end up with this mess, this hodgepodge of mess, where initially we may be able to compensate, but pretty soon it's like uncle and we can't compensate anymore. So back to that moment, I'm on this exam table, and I'm 29 years old, thinking I'm going to be in a wheelchair, you know, literally. And I remember just having a moment thinking, you know, I just want to know why. And then I remember saying, you know, to myself, if I can get out of this, I'm going to make dang sure I can help people. So that's what I'm here for today.
Well, I appreciate you sharing that, and I think you know, I can personally resonate with that as someone who's, you know, in school, suffering through all sorts of chemistry to become a clinician, hopefully. And I know Josephine, who's also helps Sergeant Headway. She's one of our co-founders. She's becoming a military physician and helping serve those who serve our country. So I think that is something that we can all definitely relate to, and appreciate you opening up to us like that, because we know it's not easy. What do chiropractic functional neurologists look at? Like, what sort of in the chiropractic and the functional neurology training allows you to sort of look at the big picture approach when sort of assessing a post-concussion individual? So what are some things that you are looking for and looking at when you see someone in clinic?
Okay, so the big thing is that the neurological training when it comes to the brain is taught through the Carrick Institute, which is a postdoctoral program that you're allowed to take at the same time as you're a student. There are other programs out there. That's the one I'm familiar with, so that's the one I'm going to speak about. And I'm also a member of the American Chiropractic Neurology Board. We have the different programs that you can take to specialize in neurology are listed on that site, acnb.org. Okay, so the thing, let's just kind of take it big picture. I'm a big picture person, which is kind of funny since my degree is mechanical engineering, but big picture concept-wise, the brain is the brain, right? So there's multiple people that are working with the brain, and my biggest thing is that I want people to do better and feel better and have their quality of life. So I'm going to speak on what I know and do my best to just represent that. So the thing is that my training is through the Carrick Institute. Dr. Carrick is the founder of the Carrick Institute. He's a great gentleman because he saved my life, which is a wonderful thing. The applications that I have learned in terms of the concepts that I think are most important to convey is that when we're looking, and again, I'm speaking kind of in the context of, you know, the field as a whole, but there's multiple subsectors and multiple variants within the field. So again, I'm speaking to what I know. So the brain functions in multiple systems working so that we can always have some fail-proof substructure to allow us to accommodate to multiple variables. So the thing that I think is the most unique in terms of a functional neurological construct is to analyze multiple systems and look at the dynamic interplay between those systems. So for example, if someone has a vestibular disorder, meaning they may be dizzy, they may have vertigo, that sort of thing. They may have some sort of aspect where their eyes may not be doing what they wanted to do. We are also going to want to look at how their sensory system is working, so that, are they getting the same sensory information, left versus right? What is their motoric, actual muscle tone underneath the surface? Because a muscle tone is always giving feedback into the brain. And so, for example, for my condition, when you have tight muscles and they're not allowing, so you can picture muscles have sensory receptors in them, and they allow the brain to have feedback about where you are in the world, so proprioception. When there's a tonic tightness in muscles, and that's set by the brain causing the tonic tightness, or there could be some sort of local inflammatory cause of the tightness, your brain's going to be deprived of that sensory information. So if you're not moving your neck as much as you normally should, and your vestibular system is housed in your ear, and say I'm not turning my head as much to the left, that's going to totally change my vestibular integration. So someone may present with vestibular dysfunction, but it could be a consequence of maybe this is the primary nidus of what we need to identify, or it could be coming from, tightness could be coming from the brain up here setting this muscle tone for different conditions. So we look at multiple different systems and then look at how we can triage the care of the person's dysfunction. So my thing, anytime that I'm working with a new patient, I ask them, what is your goal? Like, if we could put, your top 3 things in order here, what is the biggest thing that's limiting you from your quality of life, from your life experience that kind of drives you bonkers at the end of the day or during the day? And because the thing is, on any one person, you can have some sort of, ankle injury from the 1970s that's going to change the feedback from their ankle mechanics into their brain, and it's going to affect a lot of different things. But if they're like, hey, I just really want to bend my pinky, you might have to do something a little bit different depending on the person. But the thing is, for looking at function, or looking at function, say, of an eye movement, there's multiple different systems that feed into the ability to move your eye to the left. So there's fast eye movement systems called saccades. There's slow eye movement systems called pursuits. There's reflexive systems called vestibular ocular reflexes. All of those systems feed into the cell groups that are associated with moving your eyes, for example, to the left side. So when we're looking at someone who may have a deficient ability to move their eyes to the left side, we can't just say, let's just train this eye movement to the left side, because if we do the task where they're failing, it may promote more failure. And I think that's probably the biggest thing, that that the takeaway point is that just because something is weak or doesn't work doesn't mean we may be able to go in there and directly rehab it, because it may not be tolerable or it may not be conducive to rehab. So same kind of concept. If a person has muscle weakness on one side of their body, so let's just use the left side, and the left side of weakness is in their bicep and shoulder muscle, and they find that their shot is a little weak. For hockey, for example, we may not just be able to strengthen this left side, because it may not be something to do with strength. It may have something to do with the ability of their parietal lobe, for example, on their right side, to be where it's not able to be metric. So the parietal lobe helps to assist in metric activity. So we may be looking at a finger to nose type activity and deduce that they may be hypometric, meaning they fall a little short of the target, specifically in one field more than the other. And we might say, hey, guess what? Your weakness that you have in this left arm and your perceived inability to move this left arm is actually coming from an error in your ability to be accurate with that left arm. So the biggest thing is kind of how, each part of the brain wears a different hat, but each part of the brain works together collectively as a team. So I think the biggest goal of functional neurologists is to, I think globally, we're all getting better as clinicians, working together to diagnose different conditions. I think one of the biggest things that we can improve on collectively is have a shared language of how we're describing things, the methodology for how we're intervening. And, I look forward to other physicians that are on this panel to talk about that also.
That makes a lot of sense. It's a very solid explanation, and it takes me, I'm in a movement science class right now, which is all about different parts of the brain and motor control. It's interesting. What are some of the common issues that you see in the clinic? So what are some common presentations post-concussion? Now, I do know that every concussion is different, but there likely is some common trends in people that you see. So if you want to touch on some of that.
Yeah, well, one of the things, first off, that I see too often is that people don't come in after the first concussion. So they're coming in, and we're not getting a baseline prior to concussion. So that's one of the things that I'm personally striving towards, is I'm working to collaborate with a local university here to try to get that, some of that worked out, because I think that that would really matter. So but again, in the clinic, we're seeing people, unfortunately, after multiple concussions, and that's kind of their uncle. You know, their white flag goes up after multiple concussions. They're not able to go into the game or the sport or the life that they want. And what I would advocate for is actually to have an exam by someone that is skilled in examining concussions, and get examined after the first one and have an intervention after the first one, because I think what can really happen is people are going back to a sport before they're rehabbed, and they're going back there with a compensatory possible strategy, and they're at risk for a greater injury. So in my personal clinic, I'm not just seeing concussions. I'm working with people of all different maladies. It could be literally some acute sprain strain. It could be a chronic condition. It could be a post-stroke condition. It could be just a balance issue. It could be all sorts of different things. But in terms of concussions, I think a lot of people, and I'm just going to go back to this point because I think it's worthwhile, are coming in with concussions from sports. And I think one of the biggest obstacles that we have is that people that are coming from, especially a higher caliber sports, or even they're just really driven athletes, are not going to admit that they have something wrong. And so I would advocate for people to, and what I think is so great about this foundation is to really seek help, and let's try to do something before a bigger injury happens where it really takes away from your quality of life. So in terms of, you know, signs or symptoms associated with concussion, I really have my personal approach is I read through the history, I read through all the scans, I read through whatever they give me, I have a thorough assessment before I even see the person of all the information I have, and then I literally tell myself, don't expect anything. Because I think when I can go into it clinically to not expect to see this or not expect to see that and not have a bias on what I may see, then it opens myself up to look at where am I able to identify where this person's system fails, and that will be unique to them. So it may be when they're walking with their head turned to the left is when the whole system kind of drops out on them. And we're not going to find that until we do a thorough analysis. It's almost like a choose your own adventure book where we kind of skip to the next chapter once we kind of go down the trail. And then in that regard, we're looking at where that person's system triages, where that person's system uniquely fails for them. And when I'm talking about failure, I'm talking about dysfunction, where we have an ideal level of function and then we have a not ideal level of function. So failure means we're not able to kind of maximize that ideal level of function, and it is clinically significant and personally significant for the patient.
So you touched briefly upon this, but if you could elaborate a bit more, how important it is to, when evaluating a patient, sort of look at, you know, how the patient functions at rest versus when fatigue versus incorporating movement, because, you know, how, like, let's take, you know, an ice hockey player as Headway's probably preferred sport, you know, like how an athlete might do, you know, sitting on an exam table versus when you're putting them on the ice, and what sort of dysfunction might arise that might put them at risk when they attempt to return to play, or maybe if there's a gap between, you know, what's happening when, you know, someone is sitting doing nothing and their symptoms and when they are put in a classroom, and sort of how you as a clinician can gauge those sort of different types of demands and how the dysfunction presents.
Yeah, so one of the biggest things that, and that's something that's really passionate about for me personally, so thanks for asking that question. It's a very good question. So the thing about it is it's task dependent. People's aspect where they're going to have their symptomatology is task dependent, and that's a term that's actually very common in the movement disorder science field, where we're looking at a task specific failure or a task specific presentation. So no kidding in here, like if somebody says, you know, I'm feeling this at work, we mimic work. We set up a desk, we put the door where the door is, we move stuff around, we get the lights where the lights are, and we have people come in where the people are coming in, and we look at what happens. Or if someone says, I feel this when I'm golfing, then we get them with the golf club, and I'm on the floor and I'm looking at their eyes, at what they're doing and different things when their head and their body is in different positions. Because when you're recruiting muscles different to the task that you're actually doing. So say if you're actually going to put your hands on the keyboard and you're actually going to start typing, your eye movements and your ability to stabilize your head is completely different than if your hands are just at rest and you're sitting at a desk. So a lot of, one of the biggest things that we look at, my personal clinic, and I, again, I'm kind of speaking with what I know, what I think is fair. So is we modify people's environment so that they can best succeed. So we've been known to rearrange a lot of offices and a lot of classrooms to best facilitate people to either be able to adapt, because that's one thing, or it can be set up so it's actually more therapeutic for them. But sometimes we just got to get by. So sometimes we're like, hey, listen, it's easy for you to do this task. You're going to do better when someone's coming in from your right side. It's not going to drive you bonkers. So we're just going to set it up that way right now until things are more stable with your at-home program. And then we're going to rearrange things so that you can start to develop an ability to withstand the insult, really, of the environment of things coming from that left side. So, and then, for example, we were looking, sometimes I'll look at video. So someone says, this happens when I'm doing a deadlift. So then we'll look at a video analysis, or we'll try to break it down in the office with someone doing that task. So oftentimes we're looking at the task-specific challenge where someone has the evoked symptom, or they may not have a symptom, because what's really cool about the brain is it helps us inhibit symptoms. But one of the questions I often ask is, when do you feel best? And that gives me an indicator of what environment is really cool for them. So then I'll ask the variables. What's in that environment? What's happening in that environment? How can we replicate that environment? And then I say, when do you feel the worst? What thing gasses you the most? And then from that, we can also gain and kind of focus our, our binoculars right on what things may be really problematic for that person. Because since the brain is always doing all of these, beyond what we can even wildly imagine is the way I picture it. It's infinite. So we have all these variables in our lives that are infinite, and embracing infinity actually gives us the ability to be creative in our exam and the ability to be creative in our application. So on average, no one person should have the same drill and the same kind of cocktail of rehab, because each person is uniquely really crafted uniquely and beautifully, which is pretty neat.
Makes a lot of sense. One thing I would like to ask you, just because you do have this unique combination of clinician and then also seeing things from the patient and athlete side, is when you are dealing with concussion recovery, especially in the PCS realm, when you're getting into this chronic phase of concussion symptoms, when you are doing the rehab, I think a lot of people within our circle struggle with sort of when to push through and when to sort of take it back, and how to sort of balance, feeling worse and pushing limits to make strides versus getting back into life, whether it means, going out to a movie with friends and feeling worse off the next couple days, or, staying in for the night and doing some therapeutic exercise. Or sort of what's your take as a clinician in terms of pushing it in a therapeutic setting, but then also in terms of return to life? What's your take on that?
Yeah, so the biggest thing, and this does come back to personal experience, and I forget sometimes until I'm, have someone, cry in the exam room and say, you get it, or this sort of thing, that the personal history matters. So I know what it's like to lose stuff. I know what it's like to lose things that make you you. So one of the things that I look at is like, hey, listen, this is the thing. We're in a recovery phase right now. This is like big time. We need to focus our efforts. We need to calibrate, your energy output right now, so we can be really strategic on making sure that you meet your goals for function, right? But what I ask people is I say, what are the couple things that we need to keep present to make you feel like you? Because if we can do that in the process of still having you get to the point of recovery, we need to keep those in there so you are happy, so that you feel like yourself, So if someone wants to go to the movies, and that's really important, for example, this one woman, she wants to wear high heel shoes. And that's not my goal. That wouldn't be something that I would pick to do.
Not mine either.
Yeah, but she wants to wear high heel shoes. So God bless her. We're going to let her wear high heel shoes on this event, and we're going to do some damage control before it happens and some damage control after it happens, just so she can wear some high heel shoes. And she loved it. It was awesome. So I think that is something that I think if we all just look at the aspect, like you were talking about your brother in med school, if we can all just look at the aspect of putting ourselves in the person's shoes and saying, it's literally, right, in high heel shoes, then I think that if we can say if you really want to go to the movies, let's come up with where you're going to sit. And if you're, who's going to sit on what side of you, how far from the screen you're going to be, how are you going to be on the left side or the right side of the theater? When you are walking out of the theater, do you want to turn left to exit so people are, exiting in front of you and they're like moving to your left, or do you want to walk right to exit so they're exiting to your right? Which one's going to be easier for you? So in those situations, it's not like we're going to have you go in there and do rehab while you're in the movies. We're going to come up with the variables that we're able to identify. We're not going to be able to identify everything. That's impossible. But what are the things that we can hang our hat on to know that our probability of you going into the movies then has a best outcome where it's not as deleterious for your life,
Yeah, no, those are all really good take-home points, because I think people do develop, I think, a fear of feeling worse, especially when they've been feeling so bad for so long and might make, a couple steps forward and they're scared of falling back. And, feeling bad is not fun. So you don't want to make yourself worse. And I think that it's a common topic that's talked about within our circle community is sort of, oh, I did this today and it made me feel horrible. So, crossing that one off the list. And, that's not necessarily a mentality that should be encouraged, because, you do still want to live life and, put yourself out there, and you don't want to lose pieces of you due to an injury. So I'm glad that you can attest to that, and that there are ways around it from a clinical standpoint. Just requires a little bit of extra thinking. So that was some really good perspective. Just sort of the last thing I want to touch upon, and you've already spoken a little bit about it, is, Headway's new tough concept is this idea that, as an athlete, it's actually harder and should be encouraged to go against your, natural instinct to push through and actually report your symptoms, make changes, before the, symptoms become, so bad that, you have to cry uncle, as you've put it, and, taking the necessary steps to, have an action plan in place before you play your game, know before you start your season, what happens if I do take a really bad hit and start feeling out like myself? What happens, what sort of plans are in place if something occurs in the moment? And what if, 2 days later, I'm feeling kind of funky, or what if I'm a teammate and, I notice that, my D partner isn't feeling very well. And, I owe a lot to my D partner who told my coach I wasn't feeling very well, or I wasn't quite right and I wasn't playing well. And, they took me out of the game. It was because my D partner spoke up that, things could have been worse. So sort of what are your feelings on sort of this as an athlete, and then also as a clinician in terms of implementing it? I mean, you obviously think it's a good idea, but sort of in how we can see it turn the corner in sports culture and actually implement it around where you are and around the country.
Well, I think that that's why the foundation is so important in terms of awareness, right? So if there's a problem and you're making people aware of the problem, which is happening right now, then that's going to help implement hopefully a culture of change. I think that headlines with professional athletes unfortunately suffering from concussions that are lifelong and severe helps, because now a coach who may have said, that's okay, get in there, because unfortunately the coach has a lot of mental power over the athlete, because it's like jump, how high type thing, so as a coach becomes more aware also, I think such a big campaign in terms of allowing an athlete to feel comfortable to speak up is really through education through the coaches, and allowing the coaches to realize what is and is not right, because a lot of coaches maybe, I'm 38 years old and I was competing when, in 1998, 2002 in college. And at that time, no one even talked about a concussion. I mean, it wasn't even, it was like, cool, you see stars? Awesome. Can you make it the next run? Cool, good job. So I think that hopefully we can get away from that culture coach wise. And I think that from this kind of athlete up type thing is really going to be the successful way to do it because of living it. There's nothing more powerful than saying, it's important to provide a culture where the athlete feels safe to say, I'm not feeling well. And then on our end, as clinicians, we need to keep doing our due diligence to learn the best that we can and take care of people better every day.
Couldn't have said it better myself. Well, thank you so much for giving us your time and sharing your incredibly powerful story. We really appreciate it. And yeah, so thank you so much.
Thank you for having me.